Welcome back to the deep dive. Today, we are cutting straight through the noise to get to the absolute essentials on a huge topic: the drugs we use to manage heart failure. Our mission is pretty clear. We're going to distill the core insights from the nursing pharmacology literature. We're talking mechanisms, safety alerts, and, the really crucial nursing considerations that give you a complete picture of how we treat a failing heart.
And this dive is so incredibly important because heart failure, or HF, it's not some simple diagnosis. It's a really complicated clinical syndrome.
Right.
It basically represents the heart's inability to pump blood effectively enough to meet the body's metabolic demands. And when that central pump starts to fail, you just get this systemic backup congestion, and it affects every single major organ.
Okay, let's unpack that, this idea of a system failure. Before we even get to the drugs, I think we need a quick handle on why the muscle stops working so efficiently. So our plan is to cover that foundation, how the heart contracts and why it fails. Then we'll look at the body's own attempts to fix it. And finally, we'll dive deep into the three big drug classes: cardiac glycosides, phosphodiesterase inhibitors, and the newer HCN blockers.
Okay, so let's start small, cellular level. Muscle contraction, it all relies on this functional interaction between two proteins, actin and myosin.
Okay.
They form these little bridges in what's called the sarcomere. Now, the key ingredient that unlocks all of this is calcium. In a healthy heart cell, when it gets stimulated, calcium just rushes in. It inactivates this other thing called troponin, and that allows those proteins to grab each other and contract forcefully.
So it's an electrochemical process.
Exactly. And our source material points out that in a failing heart, the cells, they just lose the ability to effectively use energy to move those calcium ions around.
Wow.
Think of it like a machine that can't manage its fuel supply. The result is just a weak, ineffective contraction.
And what's triggering this massive mechanical problem?
Well,
What are the main causes of HF?
the overwhelming driver, the biggest one by far, is coronary artery disease. It accounts for something like 95% of cases.
Wow.
Yeah. Lack of oxygen to the muscle is pretty much a death sentence for its function. Beyond that, you see cardiomyopathy, chronic hypertension, forcing the heart to constantly pump against super high pressure, and valvular heart disease, which leads to chronic volume overload.
And when that failure kicks in, you start seeing these very distinct clinical symptoms, right? It all depends on where the blood is backing up.
Yes, and that gives us the clinical picture.
So tell us about that. What does that congestion actually look like in a patient?
Well, if the left side of the heart fails, blood backs up into the lungs. That's pulmonary congestion.
Okay.
So you'll see shortness of breath, dyspnea, rapid breathing, or tachypnea, and orthopnea. That's difficulty breathing when you're lying flat.
And that's the one where you ask about pillows. Right?
Exactly. A key measure in the clinic is just quantifying it by asking, how many pillows do you need to sleep comfortably? In really severe cases, we hear crackling lung sounds, rales or wheezes, and sometimes even hemoptysis. That's blood-tinged sputum.
So if the left side is pulmonary, backing up into the lungs, the right side has to be systemic.
Exactly right. Right-sided HF means blood is backing up into the rest of the body, the systemic circulation. This shows up as elevated jugular venous pressure, or JVP.
You can see it in the neck.
You can. Also, liver enlargement, hepatomegaly, and the classic dependent edema, that pitting swelling we see in the legs and feet.
You mentioned an interesting detail about that, nocturia.
Yes, nocturia, frequent nighttime urination. It's a neat detail. When the patient lies down, all that fluid that was pooling in their legs shifts back into circulation.
So it perfuses the kidneys better.
It increases blood flow to the kidneys, and that leads to more urine production overnight.
And it's so critical to remember, since the whole system is a closed loop, that failure on one side, if you don't treat it, it just inevitably leads to failure on both sides.
It absolutely does. And the heart is failing, but the body doesn't just give up. It tries desperately to compensate for that decreased cardiac output.
Yeah.
It uses two major mechanisms, but they ultimately make the whole problem worse.
They backfire.
They do. First, you have baroreceptors that recognize the low pressure, and they trigger sympathetic stimulation. It's like a constant shot of adrenaline. It increases heart rate, blood pressure, boosts the force of contraction.
And what's the second, more complex mechanism?
That would be the activation of the RAAS, the renin angiotensin aldosterone system.
Right.
The kidneys sense low perfusion, they release renin, and that starts this whole cascade that leads to massive vasoconstriction and fluid retention. The goal is just to crank up the pressure and the volume.
So, okay, these responses, the sympathetic overdrive and the RAS activation, they sound helpful in the moment. But why is this the ultimate self-sabotage for the heart?
Because they just dramatically increase the heart's workload. Imagine a sprinter being forced to run a constant marathon. The heart muscle starts to enlarge, that's cardiomegaly, which, you might think bigger is stronger, but it's actually less efficient.
It's just more worse.
It's a constant, unnecessary workload that just accelerates the failure.
And that really sets the stage for our initial treatment strategy. Before we even think about drugs to boost the pump, the first goal is always to reduce that counterproductive workload.
Precisely. We have to decrease the strain. So we use vasodilators like ACE inhibitors and nitrates. These are essential because they tackle two really important concepts: preload and afterload.
Can we just pause there and define those?
Yeah.
Because you hear them all the time in cardiac care.
Of course. So preload is the volume of blood that's stretching the ventricle walls at the end of relaxation. Basically, it's the load the heart has to deal with before it even contracts. And afterload is the resistance the heart has to overcome to push that blood out into the circulation. Vasodilators decrease both. So you get less fluid coming back to the heart, which is less preload, and less resistance to pump against, which is less afterload.
Less volume, less resistance, less work. Simple as that.
That's the goal. We also use diuretics to get rid of excess blood volume, which also reduces preload. And critically, specific beta blockers are used: carvedilol, metoprolol, bisoprolol.
That seems counterintuitive for a weak heart.
It does, but when they're given very carefully, they actually decrease overall mortality because they minimize that chronic damaging stress from the sympathetic nervous system.
We should also touch on two important combination drugs that kind of break the traditional mold. First one is Bisdil. That's a mix of isosorbide dinitrate and hydralazine.
Bisdil is a really powerful example of pharmacogenomics in action. It was specifically approved for self-identified African-American patients with severe to moderate HF.
Why that specific group?
Because research found this population was often less responsive to the standard RAAS inhibitors, like ACE inhibitors. So this combination provides a really targeted, effective vasodilation for a specific subset of patients.
And the second one, which came out in 2015, is Entresto. It pairs valsartan with a drug called sacubitril. What's so novel about sacubitril?
So sacubitril is a neprilysin inhibitor. Neprilysin is an enzyme in the body that breaks down these naturally occurring substances, including natriuretic peptides.
And those peptides are the good guys here.
They are. They help you excrete sodium in water, which reduces volume and workload. By inhibiting their breakdown, Entresto basically supercharges the body's own natural ability to relieve strain on the heart. It's a very effective tool against that congestion.
Okay, so once those first-line strategies are maxed out, then we turn to the cardiotonic agents, or inotropic drugs. These directly increase the force of contraction. That's a positive inotropic effect. To boost output, increase blood flow to the kidneys, and counteract all those RAAS effects. Let's start with the oldest, most famous one, the cardiac glycoside prototype, Digoxin.
Digoxin is powerful, but it's complicated. Its core mechanism is increasing intracellular calcium, which leads to that stronger contraction.
Positive inotropic effect.
Yes, it increases the force of the contraction, but has two other really critical actions. It slows the heart rate, that's a negative chronotroping effect, and it slows conduction through the AV node. So it's used for HF, but also for arrhythmias like atrial fibrillation.
And this is the drug that's famous for having that razor-thin margin of safety.
It is, which means the nursing considerations are absolutely critical. The therapeutic dose is incredibly close to the toxic dose. The range is just 0.5 to 2 nanograms per milliliter.
That's tiny.
It's tiny. Because of this, the nurse has to check the apical pulse for 1 full minute before giving it. If that pulse is below 60 in an adult or below 90 in an infant, you have to hold the dose. No question.
And what are the signs that a patient is tipping over into toxicity?
Well, we watch for headache, drowsiness, GI upset, and the classic, very distinct visual changes. People often describe seeing a yellow halo around objects.
Wow.
Yeah. But arrhythmias are the most serious and potentially fatal sign. We also have to remember that digoxin is excreted largely unchanged by the kidneys, so if you have an older adult or anyone with renal impairment, their risk of toxicity just skyrockets. It requires constant vigilance.
And if toxicity becomes life-threatening, what's the intervention? What do you do?
The immediate antidote is digoxin immune fab, or DigiFab. This drug works by binding to the digoxin molecules, essentially capturing them so they can be excreted by the kidneys.
So it just pulls it out of circulation?
It does. But a key safety detail here is that once you give the antidote, serum digoxin levels are going to look artificially high, and they'll be unreliable for about 3 days.
There's a really crucial clinical anecdote in the material about how fragile this therapy is. The case of GJ. She was stable on digoxin for a decade, but after a move, she quickly started showing signs of progressing HF. Weakness, edema, orthopnea. Her serum digoxin level had just plummeted.
And this is a perfect illustration of what we call implementation sensitivity, the suspected cause. It was just a change in how she took the medication.
That's it?
That's it. She had always taken her dose on an empty stomach in the morning, but at the new facility, she was getting the oral drug with food, specifically ice cream, in the afternoon.
Oh, no.
Food and antacids can drastically reduce the oral absorption of digoxin, making the treatment completely ineffective. It just shows how a minor change in timing can derail a life-sustaining treatment.
That's incredible. Okay, let's move to the second class of inotropes, the ones we save for the really severe cases, the phosphodiesterase inhibitors. The prototype is milrinone.
Milrinone is strictly for short-term treatment of severe HF that hasn't responded to anything else. Its mechanism works by blocking the enzyme phosphodiesterase. This increases a cellular messenger called KMP, which ultimately increases calcium levels, leading to a stronger contraction and significant vasodilation.
The powerful 2-for-1, it boosts contractility and reduces resistance. But what's the major trade-off that keeps it short-term and IV only?
The risk. The risk of potentially fatal ventricular arrhythmias is very, very high. Its use is highly restricted to closely monitored ICU settings. And another huge safety note for anyone giving this drug, milrinone forms precipitates if it's mixed with furosemide. So you absolutely must use separate IV lines if both have to be given.
Good to know. Finally, let's talk about the newest class, approved in 2015, the HEN channel blockers, specifically ivabradine. Now, this drug is a complete outlier because it does not boost contractility.
That's right. Ivabradine is purely about rate control. It works by blocking these channels, the hyperpolarization-activated cyclic nucleotide-gated channels, in the heart's natural pacemaker, the sinus node. By blocking them, it slows the firing rate. It just slows the heart down.
So what's the benefit of slowing the rate if you're not increasing the squeeze?
It's a great question. By slowing the heart rate, you extend the period of filling diastole, which allows more blood to enter the ventricles.
Oh, okay.
This improved filling time increases the stroke volume, and so it improves the overall cardiac output. And it does this without all the systemic effects you see with beta blockers.
It sounds like it has a very specific patient profile then. It's not for everyone.
It definitely does. It's indicated for stable, symptomatic, chronic HF patients who have a low ejection fraction, so at or below 35%, and are in sinus rhythm. And critically, the patient must have a resting heart rate of 70 beats per minute or more.
So 70 is the magic number.
70 or more. And they have to already be on the max tolerated dose of beta blockers or have a contraindication to them. It's really for rate control when other strategies are exhausted.
And are there unique adverse effects linked to blocking these pacemaker channels?
Yes. Besides the expected bradycardia and hypertension, ivabradine is associated with a specific visual disturbance. It's called luminous phenomena.
Luminous phenomena?
Yeah, patients report sudden changes in brightness, flashes of light, or seeing colored lights. This requires some really careful safety counseling, especially about driving or operating machinery.
Wow, this has been a really profound overview of the entire heart failure arsenal.
To kind of synthesize these 3 core mechanisms, digoxin is the classic. It increases calcium for contraction while slowing the rate, but it comes with huge safety concerns.
Right.
Milrinone is the short-term, high-risk, potent boost through the CAMP pathway. And ivabradine is the specialist. It focuses purely on slowing the SA node to improve filling time, used only when the patient's rate is too high, despite everything else we've tried.
So what does this all mean for you, the learner? The treatment of heart failure is this precise, multi-step process. First, you reduce the workload. Then you selectively boost the pump, or you slow the rate. The big takeaway here is the absolute criticality of managing these drugs, particularly that narrow safety margin of digoxin, and how something as simple as drug timing, like we saw with GJ, can derail an entire regimen.
And building on that GJ scenario, given how critically dependent these patients are on stable drug levels and, perfect adherence, consider this. What broader systemic failures in hospital discharge planning, medication reconciliation, institutional care structures, what failures could amplify that risk of toxicity or therapeutic failure for vulnerable people like the elderly? It goes far beyond just whether they take their dose with ice cream.
A really crucial thought. The stability of their daily routine is inseparable from their clinical stability. We hope this deep dive into heart failure pharmacology provides you with the clarity you need.
Stay informed and keep digging into the details that truly matter.